Chef AJ Live. I'm your host, Chef AJ, and this is where I introduce you to amazing people just like you who are doing great things in the world. You know, one of the best things about my job as the host of summits is that I meet amazing people, and I'm hosting a GI summit this year, a little bit later in the year. And I was interviewing Dr. Will B, the New York Times bestselling author of Fiber Fuel, who's a plant-based GI doctor. And I said, you know, the summit's going great, but there's too much testosterone. I need some estrogen. Do you know any awesome gastroenterologists that are female? And he said yes, and he introduced me to today's guest. And I interviewed her, and I was blown away by her brains and her beauty, and did not even know at the time that she is plant-based. And many of you write me every day with problems that you're having with your GI tract, specifically bloating and all kinds of things. That's the reason I'm doing this summit. And she actually can do telemedicine, even if you're not in her state. So you're going to get to know her today. She's absolutely amazing. Her name is Dr. Janese Laster, and she's going to be talking about a gut check for weight management. Please welcome Dr. Laster. I think you're amazing.
Oh, thank you so much. Thank you for having me. I'm so excited to talk to you again. We had such a good time the first time, so I'm looking forward. You asked good questions.
You're like the best kept secret in the plant-based world. So I want to make sure everybody knows about you, and they will, if I have anything to do with it, either by watching or share this broadcast, guys, because you know how hard it is to find a GI. Well, it's not that hard now. There's like 4 or 5 of you, but still ones that can actually talk to us if we're not right in front of you. And you just started a new. Well, first of all, I want to say you're not only a board certified gastroenterologist, you're also board certified in internal medicine, in obesity medicine, and nutrition. You're a quadruple threat. That's amazing.
Yes, I'm a person who apparently loves to study for board exams and spend a lot of money on tests.
Yeah. So you just started a new business. Tell us about it. It's in Washington, D.C., which I call Barnard country. So that's amazing.
Yes. My joy for plant-based diet and helping patients trying to understand what goes on in their gut and kind of how to overhaul their gut, and decided that there wasn't really a place where I fit in kind of traditional GI practice. So decided to create my own space. And it's called Gut Theory, Total Digestive Care, and providing everything on the spectrum for weight management and gut health, from discussing kind of comprehensive diet and nutrition plans, providing meal replacement services of food that I've actually tried and is not full of crap, so I like it. Plant-based home food delivery services for people that are super busy and always on the go, which I use as well, from a company called Plantable. In addition, sometimes people need some additional tools. And so I wanted to be able to have people have everything they need. So we also have in-office pharmacy for weight loss medications. And in addition to that, I do bariatric endoscopy. So there's non-invasive ways to help people lose weight. So for those patients that would be eligible for a gastric bypass or a gastric sleeve, but don't want to undergo the risk, or, you know, some other reason they don't want to undergo surgery, there's a little segue, an intermediate before you get to surgery that's less invasive and incisionless. And most people don't know about them. But intragastric balloons and endoscopic sleeve gastroplasty. Those are 2 endoscopic techniques. And that means there's no cutting. It goes through your mouth and you're asleep. You don't feel or remember anything. And you wake up and you either have a balloon or a smaller volume stomach from sutures from the inside. So I think they're pretty cool and kind of innovative and kind of where we're going in medicine. And I think right now is kind of prime that a lot of people are seeing how much kind of their diet and excess weight and what that does to your overall health. And I think people are starting to say, you know what, it's time to kind of have an overhaul. And so I'm going to be there in that process. That's the most fun part, is when people decide they want to start that change and being able to guide people through that process. So that's my baby that I just announced, and I'm excited. It's going well.
Well, it's so interesting because I didn't realize there was non-surgical weight loss surgery. And I have a friend whose dear uncle died from gastric bypass. So this definitely sounds a lot safer. But do you ever counsel patients on maybe not even having to have that procedure and just doing like a lifestyle change, dietary lifestyle change?
100%. One thing that I always tell patients is nothing is a one-stop shop. Even if you go and have a gastric bypass or you have a gastric sleeve, the only way for it to sustain weight loss and weight management is a lifestyle. It has to be overall. It has to be comprehensive. So that's always where we start. I want to know everything. I want to know kind of what your diet has been. I want to know what your life is like. I want to know what roadblocks and barriers you have. If you have kids or a husband or you travel a lot, if there's a lot of stressors or sleep, or you take care of multiple family members. There's so many things that kind of are barriers for people. And it's always a way. I can always find a way to navigate that road and to be able to help people to find a solution that works for them, because everything doesn't work for everybody. So that's kind of the goal for me, is to find that thing that works for them, and making sure that we start there, because that's the foundation. Everything else is kind of, added things on top and little side items. But I think the foundation is certainly trying to understand and teaching people what healthy eating actually is. Because depending on where you are from in the country, I'm from the South. So in the South, a healthy meal is, and somebody showing they love you, is a nice fried chicken and macaroni and cheese and cornbread and, collard greens, but definitely not healthy ones. And that's what, love is and what a nice meal is. So trying to change that mindset goes kind of a long way. So that's always first.
Well, it's interesting because so many doctors don't really even ask patients what they eat, but as a gastroenterologist, you do, not just because you are one, but because I think you eat healthily yourself. I'd love to know your story about how you became plant-based, because
So that's funny, because like I said, I'm from Birmingham and all things are fried in Alabama. So, and my dad jokes with me now when he comes to my house that I have no food, and he can't believe that he feels poorly for me, because he's going to bring me food next time, because I clearly have nothing to eat. But, and for me, it started during my training, and seeing so many young patients. This is so present now because of Chad Boseman's recent passing of colon cancer, but seeing so many young patients with colon cancer, so many patients with excess weight and complications of diabetes or high blood pressure. And, and I was really trying to understand kind of where that came from. And as we realized, it's, kind of started with diet. And I realized, it doesn't have to, I think people sometimes, especially in the Black community, they think that as you get older, that it's just that it's inevitable that you get high blood pressure, diabetes. And I said, well, wait a minute, it doesn't have to be that way. And the thing that actually runs in families are diets. Now, not necessarily the diseases, is what we're eating. We all eat the same in our families. Those are traditions. And so that started me to say, I think I should start to eat a little better. And then I didn't know where to start. And so that's where my deep dive into nutrition, and why I decided to do a nutrition fellowship. And then I started trying to understand what happens with sort of processed foods. And boy, did I really go crazy with that one. And did a talk and a research paper looking at emulsifiers and additives and all the things that are in processed foods, and how our body doesn't know kind of what to do with those things. And then it slowly became that I didn't eat pork anymore. And then it slowly became that I didn't eat fish anymore. Then I started looking into farming practices, and that was really bad to know more about. So once I saw that, I said, okay, we don't need, and then I stopped having a craving for them. So as my microbiome changed, then I changed as to what I craved. And then it slowly became, getting rid of processed foods as well, and just eating whole foods. And it was kind of a process over, years of, just not craving things anymore. First, it came with the education piece of knowing that I didn't want these metabolic comorbidities. I didn't want high blood pressure. I didn't want diabetes. I didn't want an amputation. I didn't want to have dialysis. These are things that I've seen in my family, so these are things that I didn't want. And I wanted to help my family and my patients do better too. So that's kind of where I started, maybe 6 years, probably 6 or 7 years ago. And then kind of just slowly got to kind of where I am today, which is just plant-based and feeling great and healthy.
Did you look this good when you weren't plant-based?
I definitely feel better for sure. I think my skin is better too. So thank you for that, plant-based diet.
It's interesting to talk about processed foods, and I saw this thing, and I'll see if I can find the link and send it to you. It's called From Mouth to Anus. And it was a research that a grad student did where they swallowed a camera and they watched what happened. And they gave the subjects like real food, like they made real food. And then they gave them like top ramen and Gatorade. And they said that when they ate the processed food, it was like the stomach was confused and kind of didn't know what to do with it.
Yes. Exactly. And that's what I explain to my patients as I'm slowly getting people kind of off of processed foods. I first explained that, yes, in the beginning, you feel like you have to have this stuff because people tell me all the time, I can't live without X. Like, and it's usually like Doritos or, something. And so they always say they can't live without it. And so I tell them, you kind of are telling the truth because it's your microbiome and those bugs that are living in your gut, they want to live. So they do kind of make you feel like you can't live without them. But over time, that changes and you're able to kind of regrow and have a better population of more diverse bugs and those kind of die out. So we start kind of there to get them over the hump of wanting to try. And then we start to talk about the fact that, most people can sit and eat an entire bag of chips or an entire bag of Oreos or something and still not feel that sensation of satiety or being full. And that's because your body doesn't, your body gives you the sensation that I should eat. I need nutrients. But your brain is only looking for actual nutrients, micronutrients, macronutrients. So therefore, it's not getting that from a bag of chips or a bag of Oreos. So you continue to have this sensation of signals telling you that I'm still hungry. And so I tell people that the reason you eat more is because your body is not understanding how to adapt to this processed food. It's not sensing it essentially as food in a sense. And so you tend to eat more. You tend to eat quicker. You tend to be hungry sooner after you finish eating. And you don't get those sensors to go off to tell you that you've, reached the maximum amount of food that you eat. Whereas if you eat an apple, you're just unlikely going to be able to sit around and eat a bag of apples. You're not going to be able to do that. But it's easy to sit and eat a bag of potato chips. So those stretch receptors aren't the same for processed food versus whole foods. And so that's like absolutely true that you would see things act completely differently. Even people that have gastroparesis, like slowing of the GI tract, you'll see things, how food kind of goes through differently with like whether you have a high fiber meal or a high fat meal. And so you see things happen much differently depending on kind of what you eat.
Yeah,
For sure.
that is amazing. Well, it's interesting because you mentioned about stretch receptors, and the previous guest today was Dr. Lyle, and that's where I first learned about stretch receptors was in the book, The Pleasure Trap. And I'm thinking, even though we want people to make dietary and lifestyle changes first, and maybe only, we know not everybody's going to do that, but it seems like the procedures you do, because they're not cutting into the stomach, it leaves all the body parts intact. So you're not messing up whatever's going on there with the stretch receptors, with the microbiome.
Yeah, so kind of one of the procedures is an intragastric balloon. And so imagine we put a balloon in through the mouth and it goes to the stomach and I fill it up with saline up to about 600 milliliters of fluid. So imagine there's kind of a ball that's kind of in your stomach, throughout the day and that stays in place for 6 months. So it's as if you've eaten this meal already throughout the day. So you kind of have a little bit of a stretch there. So if you can imagine, if you eat with this kind of balloon that's in place with full of, it's dense because it's full of liquid, it's only so much you're going to be able to eat. So that's another American thing that we have is, kind of portion sizes. And so that's one of the major things too, is kind of teaching about not only real food, but also portion sizes. And so that really helps in kind of training the mind with that balloon in place, because you feel horrible if you eat too much. You really feel how much nausea and you feel like you have to vomit sometimes. And so it's really teaching you, okay, what is a good and appropriate portion size? And so the idea is that after those 6 months, when you take that out, then we've already trained your brain. So I can do smaller portion sizes. I can feel well with smaller portion sizes. So that's the goal during that period, is kind of a training period. And we take the training wheels off after 6 months. And with the endoscopic sleeve gastroplasty, if you can imagine a suture inside the stomach and pulling the stomach kind of toward itself. And that way you end up with a smaller stomach. And so one of the things that some of the physiology is shown there is that you decrease kind of motility. And so normally the stomach is kind of stretching and moving things along. And so by slowing motility, food stays in the stomach longer. So that way you feel full longer. And so there's longer time in between when you eat, and you are able to eat less as well. So that's the kind of the cool part about that, and kind of how we're playing with the actual normal physiology by, placing something that's inside to kind of make you feel more full, and also by kind of decreasing the volume of the stomach as well. So we kind of mess around with physiology there.
But you've heard of the term calorie density, right?
Mm-hmm.
So that's how I eat, in accordance with those principles. And so if I ate smaller portions, I'd starve because I'm eating such calorically dilute food. So why do these people need to eat smaller portions? Is it because they're not eating healthful foods?
Yes. Yeah. And so I tell people, and that's why I don't talk about kind of counting calories when I talk to people, which is another big hurdle to really get over, because we are a society who is obsessed with, avoiding carbs. People are very afraid of carbs, and counting calories is like, written somewhere in stone. So trying to overcome that, because I don't count calories. I just eat. I eat whatever I want. I eat all day long. I eat, people say you eat so much, and it's because I'm eating, fruit and vegetables, and I'm snacking on carrots and blueberries throughout the day, and I drink water, and I'm snacking on, so these are things that you're snacking on, and that's why I probably eat so much, because these are things that I'm snacking on. And so you don't have to cut calories. So once I get over that kind of thought process with people, then it's easier for them to understand. But in the meantime, it's trying to slowly take, get them to kind of agree with you, and it's try to bring them along with you. And it's also just, meet people where they are, because it's very hard to break through. Food is something that you can't get rid of. You need food to live. Whereas to get somebody to stop smoking or to stop drinking, you don't need to drink alcohol or smoke cigarettes to live, but you need food to live. So that's one of the hardest things to get people to change. And so taking them is slow, whatever route we need to take. I take U-turns, and we go down the forks in the road, and we try to figure out whatever we can to kind of help people to stay on track and to not feel so overwhelmed by it.
Well, Diane says you have beautiful skin. I concur.
Oh,
That's just a little segue there. The two procedures you mentioned, how long have they been around, and who invented them? Because honestly, until I talked to you on the summit, I had not heard of these two procedures.
They've been around for a while, actually. The intragastric balloon has been, the first iterations of them were not so great. They, would migrate, and they would cause perforations, which is a kind of a hole in the stomach. Or when I say migrate, I mean it will move through the small bowel, which is not what we want. And so over the years, they've been perfected and created with better shells, basically, for the actual balloon itself. And so they've been doing them abroad, in Brazil and in Europe for probably over the last 20 years. So they were there before they were approved in the US. They were just approved in the US after trials, maybe for the past 10 years. And so those are the intragastric balloons that have been and they've been around for a long time, like I said, since, they were thought of years ago, maybe, I think, when is that first trial I saw? Maybe 1990. So they've been around for a while, but they just didn't do well in the beginning. So people put them on the shelf and ignored them for a while, and then they regrouped and came back. The ESG, or the endoscopic sleeve, that one initially came about maybe about 15 or so years ago, maybe 2007-ish. And then that's slowly gotten better with different products and different sutures as well, to kind of improve upon the process. And there's other kind of machinery that have come out since then. One is a US-based USGI, which is a pose. And there's a couple others that are coming down the pipeline as well. So they've been, so at least everything has been around for, 10 to 15 years. And there have been far more studies abroad than they have in the US, but there's several centers in the US that do these procedures.
One thing Dr. Lyle has often said is never make a big decision when a small decision would do. So why, if somebody is dead set of having some kind of weight loss surgery, why wouldn't they do that first? Because once they have gastric bypass, they're mutilated. They can't reverse it.
Yeah. And you can reverse a gastric bypass, actually. It's a big procedure to kind of reverse it, and most surgeons don't like to, but there have been procedures they've had so that can reverse. The gastric sleeve, you can't reverse. You're stuck with it. Your stomach's gone. It's gone to the pathologist. And I think the reason people would go to surgery is because they just don't know about these. So I think a lot of people have no idea and have never heard of them. Even some physicians, and I did a talk about them during the Grand Rounds talk, most people had not heard of them. So I think I found out about them during my second year of fellowship. So during a retreat or a summit that I went to. So I think they're just not very well advertised. People don't know much about them unless you're kind of in that space. And for us, that space of endoscopic, bariatric, gastroenterologists and surgeons. So I think it's just not well known. So that's the goal, is kind of get the word out, get more people trained to do them. Another problem is they aren't covered by insurance. So that's another big hurdle to get over, that some of our colleagues at Brigham and Women and Cornell are submitting a lot of data and research to make sure we can kind of get to the point where we get these approved by insurance, because we think they would help a lot of patients. There's a lot of people who kind of fall through the cracks that would be eligible to get a gastric bypass or a gastric sleeve. But like I said, a lot of them don't want to undergo those surgeries. So they just are left kind of in limbo with not having much of anything. So, and also even the pharmacologic agents, I think people only remember back, the older medications that were harmful, that's what made people so afraid of them. And I think most people don't use them, even though they'd be eligible for them, because they just don't know much about them. So I think that's kind of the problem, is just not knowing kind of what's available.
Just pardon me for one moment. I thank someone for a super chat donation. Thank you so much, Gaya. I really appreciate it. So I imagine that the surgeons are not probably telling their patients that they could do this. They're probably not. Are they upset that they're getting their business cut into a little bit by these procedures?
I know a lot of surgeons that are embarking on this too. So they're being able to have, both options available. So I think a lot of them are saying, you know what, we're going to jump on this bandwagon too. So I guess if they're kind of not a surgeon who's willing to do something a little bit different, or is not as comfortable with endoscopic skills, then maybe they probably won't like it. But I look at it as, us being a continuum. It's just kind of like you only could have had a CABG, so an open heart surgery if you had a heart attack, 20 years ago. But now you have cardiologists as the intermediate to do a cardiac cath. So you don't have to have an open heart surgery. So I think at some point we'll become it'll be on that same kind of continuum of, not being such much of a competition, but, some people may need to go directly to gastric bypass if they have poorly controlled diabetes and need a massive amount of weight loss. That's going to maybe be the best fit for you. And that's something I would tell a patient if I thought that, that was something that would be the best for you. So I think for me, it's all about what's going to be the best for the patient, and like they're going to get the best bang for their bucks. I want them to increase their life years. I want them to decrease their risk of diabetes. I want them to decrease their stroke risk. So whatever's going to be the best way to get to that goal, and following and making sure they're on the right path, that's what I want. So surgery, if you need it, okay, sure.
Now, people that have gastric bypass often have to undergo psychological testing, lots of things before they're qualified for the procedures you do. Is it as stringent?
It's not as stringent, but I do believe that you have to kind of screen, which I do. You have to screen for binge eating, anorexia, bulimia, those sort of things. And we can't do procedures on patients who have those disorders. So you have to have, be referred for a psychiatrist, and we have to get those things under control, because that's only going to become a cycle and not be a good fit, and you're not going to do well overall. So like I said, I want people to do well kind of overall, because, excess weight also plays into psychological stressors and mood disorders big time. So we don't want to make anything worse. So for sure.
Right. How does one decide between the two procedures that you've mentioned? Or maybe there's more that I don't know about.
So there are more, but we'll stick with these two for now, just because it makes it easier. But I think and sometimes it's up to, sometimes we talk to the patient about it, because I feel like it's a street that we both have to agree on. And so I talk about kind of what your expectation is and what you expect after the procedure, what you're willing to go through. If it's somebody that has horrible nausea at baseline, and they have horrible episodes of vomiting and reflux, a balloon is probably going to be a horrible thing for you, because for 6 months, that's going to feel like you're completely full and you're going to have so much nausea. For the average person, if you get a balloon, you have that feeling for maybe the first day, and then it's over. And then you feel like, okay, I feel a little bit full, but I'm used to it. But if you're a person that normally has that, then it's going to be a terrible idea for you. If you are a person that needs something a little bit more robust, and you think you need something to help you for a longer period, I think maybe an endoscopic sleeve, gastroplasty, is probably a better idea for you, because the balloon is temporary. The balloon is for the person that needs that extra push, who says, you know what, I've been eating better. I've been trying to work out, and I'm at this hurdle, at this place where I can't do more. And you need that little hump to help you get down another, 20, 30 pounds. And I think the balloon is there kind of to help those people. But that being said, you have people that lose 50 pounds with a balloon. And so it just depends on where your mindset is, kind of which way, and what your expectation is, and kind of what your underlying symptoms are. And if you're willing to come back for a repeat procedure, because for the balloon, you have to have two. You have to come in to have it placed, and you have to come back in 6 months to have it removed. So it's we kind of go through everything, the pros and cons of each, and then we decide based on kind of what your expectations are, what you want, kind of what your symptoms are, what you can deal with, what you can't. We kind of go from there.
I know that lots of people that I've met that have had gastric bypass often suffer from nutritional deficiencies. Is that not a side effect with your procedure?
No, and that happens because they're basically bypassing the first part of their small gut bowel, the duodenum. That's where a lot of your kind of nutrients are being absorbed. And so you're supposed to take supplements for the rest of your life. But I'll tell you, I've had my fair share of patients who've had a gastric bypass who, if they've had it a couple years ago, they, think they don't need it anymore, because if I gained the weight back, then why do I need to take the supplements? I'm like, well, you're still clear, you're still bypassed. So there's a lot of patients that come in and, and don't take those supplements anymore. So bypass, you eat it for the rest of your life. But these two procedures, no.
That's really interesting. How did you get interested in gut health and weight management and nutrition? Because I mean, you like to study, apparently.
I think it started during my GI fellowship. I kept, we saw so many patients that came in with a lot of the same symptoms over and over again. You heard the same catchphrases. I feel like I'm 9 months pregnant. I'm bloated. I have abdominal pain. I have constipation. I have diarrhea. And we, as gastroenterologists, we would kind of do these procedures, rule out those big, bad, ugly things like colon cancer, gastric cancers, any of those things, inflammatory bowel disease. And then we, at that point, it was like, okay, we're done. We've proved these things are okay. And it just felt like, there's clearly more to it, because 80% of the patients we're seeing, it feels like, have these same symptoms. And like the elephant in the room is their diet. And I would but we only have by the time you get through all of this stuff in your visit, you have about 3 minutes left in which you can talk about this diet piece, which of course needs far longer than that. So I would quickly ask them a little bit about their diet, and you would hear the same sort of, things that people were eating. And that's kind of where my idea is. It's, I need to learn more about nutrition. I know how I eat. That's not evidence-based. I need to kind of learn more of kind of what an evidence-based approach for eating and what is healthy eating and what does the literature say, which is why I did the nutrition fellowship. And that kind of stirred all of my interest in kind of microbiome and gut health, and how nutrition plays a role in the microbiome and gut health, and how gut health kind of is, correlate with overall health. People with poor gut health tend to have metabolic syndrome with high blood pressure, diabetes, fatty liver, and how all those things kind of play a role together. So it's kind of all stemmed from seeing all of these patients that I really felt like I wasn't helping enough, that I wasn't giving enough guidance. We would just say, eat better, but what does that mean? The average American doesn't know what that means. And so that took a lot of, so it's not in traditional training. My traditional training is learning how to do procedures, learning how to do EGD, colonoscopy, learning how to diagnose. But it's not a lot of focus placed on nutrition and on traditional kind of GI training. So that's kind of where that came from. And then going to other conferences is when I started to learn a little bit more about the endoscopic piece. And I said, what, it would be really nice to be able to offer that entire continuum of care and being able to treat people from every single portion of kind of their journey. And that's kind of where that came from. It's just from the fact that I just felt like I was letting people down in a sense. And, they've come to, 10 different doctors and they are looking for an answer. And we've told them what they don't have, but we're able to help them with what they did have and kind of how to juggle that and how to handle that and what to do about it. So I wanted to learn more about that. Why is this entire country constipated, with abdominal pain and what's going on there? So learning more about kind of diet and how to help them kind of was where that all started.
Wow. So did you ever have a patient where you said, hey, I could do this procedure, or you can go on a whole food, plant-based, nutrient-rich, calorically dilute diet and get the same result? Instead of making your stomach smaller, let's just make your food bigger.
Yeah, and you really have to like test the room, because some people do not want to hear that. Some people do not want to hear about you telling them not to eat, chicken or meat. They don't want to hear it. So you really have to kind of see what your audience is and what they're willing to do. So some people are they're sick of it. They're on board. They're willing to try anything at that point. And some people are like, nope, I'll just be bloated and I'll burp and I'll deal with it. I'm not doing this thing you're telling me to do. So it's definitely a continuum. And it's funny because if I get them to do small things, I say, just give me 2 weeks of doing X, just give me 2 weeks. And if I'm crazy, you can come back and tell me I'm crazy and I'll go away. And usually they come back and they roll their eyes and they say, fine, you're right about that. And by the way, my symptom feels better. By the way, I lost 5 pounds. And I'm like, so I'm not completely, I'm a little bit crazy, but not completely crazy. So we always have a good laugh. And so it's all about, if I could just catch them with that one little thing to get them to change, then usually that starts the conversation and that kind of level of trust. So we can go a little bit further and kind of modify things better. So it's always fun to see. And sometimes it's the most unsuspecting people that actually will listen and kind of give you a shot. It's interesting. I had one of my patients, it was this guy, I said to myself, he is not listening to a word I am saying. He is not going to change a thing. And his wife was actually my nurse in the endoscopy room, maybe the week later. And she goes, I'm so sorry. You will not forget it. You had to see my husband. And I said, oh my goodness, who's your husband? And she said, and I said, oh my goodness. I said, tell me, he must not have done anything. She goes, no, he went home and overhauled and now he's so much better. So you never know who's going to be the patient that, sometimes you can't tell if they're really going to do it, but it's really nice when they do.
That's amazing. So you published a research article that I've been linking to in PubMed, and you have a podcast by the same name, Beyond the Calories. You want to talk a little bit about that? Because I thought it was really interesting.
Yeah. So one of the interesting things that we talked about a little bit earlier is people place so much emphasis on calories and how much you put in and counting calories. And I feel like people kind of spend their whole lives kind of wrapped up with calories and what they can eat and watching points and this kind of thing. And I said, well, what if it isn't just the calorie of what you're eating? And what if it's beyond what we're eating? And so I met with Leah Frame, who's a PhD and works at GW here in DC. And we met after a grand rounds and that I did at GW, and then via Twitter, actually, which is funny enough. And so we met and we talked about nutrition and had a great time. And we started talking about these kind of concepts. And I said, is it really a little bit more than just the calories we eat? It's, beyond that. And when you trend the dietary trends of kind of the American diet, you can see how much people are eating these processed foods and how that's the majority of the American diet of what they eat each day. People will have a Pop-Tart for breakfast. They'll have some type of, bologna sandwich or processed meat sandwich for lunch with a bag of potato chips. And then for dinner, they stop by because they've been working all day by a fast food restaurant and have a, processed meal for dinner. They pop in like some TV dinner or, Hot Pocket or something like that. And they've had literally the entire day of processed foods. And so, kind of looking through that data and how that's changed over time, that was my other interest is what has happened over the past, 40 years in which we're getting so much sicker. We're seeing so much more disease and then at such an earlier age. And you can see that our quality of food has dramatically decreased. And it's kind of at the same time, you saw kind of the advent of antibiotics. So the advent of people, have commercialization with people having cars and being able to drive to work. They're moving from rural areas to more urban areas. There's less walking, there's less kind of community. And there's also kind of like there was less breastfeeding. There's more formulas for milk, which made things more convenient. There's more convenient foods as well, as far as foods that are able to be microwaved and just picked up on the go. So with this industrialization, when we were getting better, we were also seeing our health get worse during that time. And so I tried to understand what was happening during this period of time and try to look at those trends over time. And that's kind of what you saw happening is you saw that people were eating much less whole foods. They were eating less grains and fiber and fruits and vegetables, and they were eating more processed foods during that time period. You saw some changes in kind of salt intake and those kind of things, but for the most part, people were eating more meat and more processed foods. And then at the same time, there was that same correlation with increased weight, increased increased incidence of high blood pressure, diabetes, and those sort of things. So I found it very interesting. And I'll say that it's, correlations, definitely not a causation, but these are things that are occurring at the same time. So they were interesting kind of correlations for me. And so that's sort of where that paper came from, is looking at the data and trying to understand what has been going on over time, what are the trends showed over time, and what is in beyond just how many calories you're intaking, what is this processed food doing? And we talk about an amazing article written by Kevin Hall from NIH that kind of studied something a little similar, in which it is a 28-day inpatient study, because it's very hard to do nutrition studies because it's so hard to control what people do. But it was 28 days inpatient. There's a control group, and there's a not a plant-based, but a minimally processed group and a processed group. And that for 2 of the weeks, they would be on either the processed group, and then they would switch over to be on the minimally processed groups. And they matched them for all of the nutrients. So they ate the same amount of fiber, protein, all that stuff. And they were not giving any limits. And what they found is when they switched people from that minimally processed to processed, there was, they gained weight. Now keep in mind, this is only in 28 days. So it's just mind blowing. They gained weight when they went from the minimally processed to processed. They noticed that their insulin levels, they were getting more insulin resistance. Their ghrelin levels, so their hunger hormone, also changed. They saw changes in their lipid levels. And it was just, and their CRP, their inflammatory marker. So it's kind of a marker we use to kind of look at metabolic syndrome and inflammation. And so it was so interesting to me that just in that short period of time that you can see changes in kind of when we look at metabolic syndrome with high blood pressure and diabetes and things that kind of all correlate, and weight, that there was a change in just those 2 weeks. And it wasn't due to the calories. It was simply due to whether somebody had a processed diet versus unprocessed diet. And so that's what we kind of were looking at in this paper. I've written a paper before about kind of going on the deep dive of what's in those processed foods that presumably are making them, not that great for us. And the interesting thing there are some mouse studies that showed the changes, and basically that we could correlate that we don't know what to do in our small bowels with those food, and our body's not understanding that, recognize them as food essentially, and them causing changes in our microbiome, changes in kind of the way the bacteria react with our cells, allowing things to get through that gut layer that shouldn't normally be able to get through. And then that having a trickle down effect of having more inflammation, an increase in that risk of metabolic syndrome, making people eat what's called hyperphagia, so people to eat more, insulin levels they're having insulin resistance. So these are the same things we saw in mice. And yes, people aren't mice, but I'm like, these are the same exact things that I'm seeing in humans when we eat these processed foods. So it was very interesting to me, and kind of being able to figure out what's happening in my patients when they eat these processed foods, and what's happening in my favorite organ system, in our gut, kind of what's happening there. So it was just kind of very fascinating to see, and to kind of put in layman's terms for people to understand, when you eat these foods, there's having a lot of downstream effects in your gut, in your microbiome, and how your body is able to metabolize these foods.
It's interesting because after interviewing so many doctors for the GI Health Summit, one of the things most of them said is that health really does start in the gut, not in the Gulf, in the gut. So maybe in the Gulf too. So what are some of the comorbidities that are associated with the gut?
With this. So one big one that there's been associations with, the World Health Organization has found with processed meats and red meats, increased incidence of colon cancer. So people with colon polyps. So that's a big risk. So over time, you're higher risk of colon polyps, which over time, without a colonoscopy and us taking them out, turns into colon cancer. We see patients with diverticulosis, which can get infected and cause diverticulitis. Or can bleed and have what are called diverticular bleeding, so massive amounts of bloody stools. And then beyond that, you can see patients that get kind of a metabolic syndrome, and you also see fatty liver. And fatty liver is very important because over time, you can see patients get fibrosis, which then leads to cirrhosis and liver failure. And most patients only consider cirrhosis in patients that have that drink or alcoholics or have hepatitis C. So it's the most heartbreaking thing to diagnose kind of somebody's grandmother with cirrhosis, and they are crying and telling you, well, I've never drank. And it's and it's really due to fatty liver. And it's from excess weight that over the years has caused this scarring of the liver. And it's becoming a major problem in the US and a major reason for liver transplant. So that's a big one for us as well. Gallstones, people needing cholecystitis, so having an infected gallbladder, having to have that removed. People, pancreatitis, GERD, and heartburn. So there's like everything in the GI tract can be affected with kind of poor diet and kind of excess weight. So, and I can think of probably a million others if I sat here long enough, but and kind of the most immediate things would be people's abdominal. The most common things we see are associated with diet are constipation, diarrhea, abdominal pain, reflux, and GERD, and let's see, nausea, vomiting. So those are very common symptoms that are in abdominal pain, kind of the most common things we see in our practice. And when we rule out everything else that's bad, of course, and make sure there's nothing else nefarious is going on with our procedures and with imaging and appropriate blood work. But after that's been done, that the next thing that we have to go to is kind of diet and what are you putting in? That's kind of the hardest thing to get people to do, because most people just want kind of something a little bit more magical to kind of make it go away. And that's not always possible. It's more usually about us getting to the bottom of it and getting a better diet profile and getting people to change some things.
You know, when we had our summit interview, I learned something from you and I completely changed the brand of plant milk I was drinking. I had no idea about emulsifiers, what they were, what they did. Since then, I had interviewed Dr. Michael Greger for the GI Health Summit, and he said that one of the companies, because of one of his videos, actually removed them. But what are they? Why are they in plant milks or anywhere, and why should we avoid them?
So they are interesting. And so they came about because they were something that was supposed to help us with kind of industrialization and make life better. And so they're not all created equally, but they were used for to make things chef stable, to make the preservatives, to make things last longer, to make things taste more palatable sometimes too. Like if you did like mayonnaise, which I don't eat, but if you ate mayonnaise, then without the emulsifier, it would not look as pretty and nice and whipped. For salad dressings, it makes things look nicer and prettier. So it makes it where people want to eat them. So a lot of cake products and pastries that you pick up from the bakeries. And so they make it to make things palatable. It makes things cheaper. You can put things most processed foods are all pretty packed with emulsifiers because they're able to stay on the shelf longer, and they're able to be made cheaper. So that was the major reason for them. Kind of the olden way of thinking of preservatives or emulsifiers were when they would cure meats in order to make them stay longer. And then we kind of got away from that and started coming up with some new ones in order to make things cheaper and more shelf stable and to look prettier. The dyes to make the colors more pretty and kind of all of these things. And that was part of that kind of dark dive I did when I was trying to figure out, well, what is this that's beyond? If it's not the calories, then what is it? And that's kind of where I started to learn a little bit more about those emulsifiers and kind of what it did to the small bowel and why, and kind of how our body doesn't really know what to do with them. And the funny thing when I learned during this deep dive is initially the World Health Organization and FAO got together in like the 1950s and decided what the reasonable limit for us to consume of these kind of products were. And then over the years, they decided to relinquish that duty to the FDA. And so it was a long process to get a new emulsifier added we had to go through multiple rounds of testing, as it should, before it was put into our food system. But then people started to really understand, like in the 90s, that this is a way to really make some money here, that we should start, getting more of these into the supply so we can kind of make more things. And the FDA got pretty overwhelmed, and the lobbyists won out with saying that we should just recognize them all as safe because they're not much different from the ones that have already been approved. But bearing in mind, in the 1950s, when this was initially approved, they were regarded as safe because you were getting so few, because there were so few on the market. So you're getting so little that was in your diet every day. But in the 90s, when the lobbyists won after, saying the FDA was taking too long, they got to generally recognize all of these as what's called GRAS, or generally recognized as safe. And so that's kind of what happened, in which we were, they were able to kind of flood the market. It went from we had about 800 to 900 to over 9,000 in that short period of time of emulsifiers and additives. And so it's so like kind of what led me to kind of look at more and to try to understand is, at this point, it's almost impossible to get a product when you look at labels that doesn't have an additive or an emulsifier in it. They're everywhere. And so when you think about that, they're in all of, your condiments that people love and use. They're in all of the milks, like you say, to keep them stable. They're in the ice cream. They're literally everywhere. And so I started kind of looking for products and milks that didn't have them, because I don't look with plant milks because I don't drink milk, but because I have to have coffee. So looking at those and saying, okay, because the ones that don't have emulsifiers, so there's only a few. But it just goes to show that it can be done. They can make these plant milks, or they can make most of these things without having these kind of emulsifiers. And so that's kind of what I did, is I try to find products and share with my friends or patients that kind of go on this journey and want to kind of get a little bit cleaner in what they're eating and their products, and try to, share brands that we always find. And I have friends in group text that we were like, oh my God, look at what I found. It only has, it doesn't have anything in it. So that's the cool part about kind of our plant-based community now, is trying to share these fun things that we find.
They have brands that are just whatever it is plus water, like soy plus water, oats plus water, almonds plus water, cashews plus water. And they are unfortunately a little bit more expensive, but they taste really good. And ever since talking to you, that's what I buy now.
Yay. And they do taste good. And it's so simple. I love them.
So people are asking, are there other names for emulsifiers or different names to look out for? Is there like a list where we can go to see if our food has emulsifiers in it?
Yeah, so some of the main ones are, the one that Dr. Greger got out of silk was carrageenan. So that's one of the major ones. You'll also see, P80 or polysorbate 80. CMC or carboxymethylcellulose is that one. You may see, those are kind of the three bigger ones. Let me think, what are the other ones? Those are the ones that have been studied the most. The CMC, the P80, and what's the other one? Oh, carrageenan are the ones that have been studied the most. And some of the other ones are, like I said, not all are created kind of equally as being horrible. But like I try to tell my patients, when you look on the back of a product, it shouldn't be a long list of things that are in whatever you're eating. If you look on the back of a plant-based milk, if I buy almond milk or oat milk, it should say almonds and water and filtered water. It shouldn't say a long list. I'm a sucker for chips. So when I get a bag of chips for my cheat snacks, it just says potatoes and sea salt. It shouldn't be a long line kind of things that you're going to eat. And so these are kind of the tips that I give, my patients and my friends to kind of just avoid it all. And so I also try to get people to avoid, if it's a food that you could pop in the microwave and you can have a complete meal, it's probably, if you look on the back of that, even if it says healthy or, lean cuisine or whatever healthy thing it says on for low sodium, I have patients bring those labels in and we talk about kind of what those labels are versus kind of what's in like a real meal. And I guarantee you it has a bunch of emulsifiers in that huge list of foods. And I had a patient recently to say, I thought I was being healthy by getting this, vegetable melody with whatever sauce on it. And it was easy and convenient, but we can find another way. By the time you get in, you can throw some broccoli, the same thing in that pack. You can throw those all, in a crock pot, go shower and come downstairs and it's done. So it's the same thing, but healthier for you, not chuck full of other stuff that take away all of the nutrient value of it, essentially.
Absolutely. And that this has just been really, really helpful. Really, the best food is food without labels.
Yes.
Yeah.
For sure.
Would you mind answering a couple questions that people wrote in advance? And so thank you. Susan wrote in, what is the specific mechanism by which a whole food plant exclusive diet can reverse colon polyps?
Ooh, let's see. So one of the ways is by increasing your fiber intake. And so there are ways to kind of feed your gut in a sense by short chain fatty acids. And those are things that kind of come from you having a fiber rich diet. And it's basically they cross the blood brain barrier, they're able to cross into the colonocytes, and they actually help feed those colonocytes essentially. And so to make sure those colonocytes are healthy, you're replenishing the mucin in your colon. And that mucin is important because it creates a barrier so that things aren't able to kind of permeate through and sneak through those barriers that they shouldn't be able to. So it kind of creates an environment of a healthy microbiome. It keeps your mucin layer intact, and it also helps with those short chain fatty acids that are very important for kind of colonocyte health and to stop the creation of polyps. The caveat to that is if you have a family history of colon cancer or colon polyps, you still need to see your gastroenterologist. Even if you're on a plant-based diet, your screening is going to be different from that of an average risk person, even if you're on a plant-based diet. So eat healthy, let's decrease the risk, but also see your gastroenterologist if you have that family history.
Right. Well, speaking of seeing your gastroenterologist, Diane wants to know if you believe it's important to get a colonoscopy. And with the death of, the Black Panther, nobody really does them necessarily on people his age.
Yeah. And that's part of what started my journey during fellowship trainings, because we were seeing so many young people that were the same age as me with colon cancer in stage 3, stage 4. And I just could not understand what was happening. And so the thing that makes me very sad about him is that he would have been 39 years old when he was diagnosed, but he was already at stage 3. And so that's one of those things that it's very scary. And that's why over the past couple of years that the American Cancer Society changed the age for screening, and they decreased it from 50 to 45. But that still wouldn't have helped him, And so one of the things that, I noticed in a lot of my male patients, and especially a lot of my African-American male patients, is, kind of a pride thing. You don't want to talk about stool or poop or their blood in the stool or anything like that. So it's really important that everybody, if you notice a change, please talk to your doctor about it, even if you think it's nothing. And sometimes it is nothing, but if, just to bring these things up. And also it's so important for us, our families, to talk to one another, because if there's a family history, we need to know about it. And in a lot of cultures, I've noticed that when I ask them about family history during our visit, they say, oh, well, my grandmother or my uncle or my aunt died of a cancer, but I don't know what kind. And that information is very important because it helps us with determining your risk because, those are things that are really important. So, and for him, as a gastroenterologist, his death it hurts all the more for me. So, because it always makes me wonder, does he have a family history? What else was going on? Was he having symptoms before that he didn't really think about? So I encourage I'm always asking all of my friends, how's your poop? I'm like the weirdo asking about poop to general public, but it's so important to have normal active bowel movements and non-bloody stools and to pay attention to those things, and weight loss and everything else. Another problem is with colon cancer, people don't feel a polyp. So when they wake up from a colonoscopy and I show them their report and I've taken out 7 polyps, they're shocked because they say, well, I didn't feel it. I didn't know anything was happening. And that's the whole reason for a colonoscopy. You won't know until you get one done.
Absolutely. What does it mean on the box of oat milk when it says hydrolyzed oats and water? Is hydrolyzed bad? I don't know what that means.
No, I think that means sometimes they will keep the oats out sometimes and they press them. And I forgot, one of my friends makes their own. And I forgot it was too hard for me to do. She'll put it in a bin and she tries, I think it's called hydrolyzing. But no, that's not like an emulsifier or anything like that. It's just kind of a process they do to kind of get the oats ready.
Nice. Good. Thank you. Julie says, I've been to many doctors, but no answers. Raw veggies pass through me quickly and are completely undigested. The only thing that I've found that helps is taking an HCl tablet and digestive enzymes before every meal containing vegetables. Is it okay to be on these supplements long term? Maybe she wants to book a consult with you.
Let's see. An HCl tab. So I would have a lot of questions for you actually to see kind of what else is going on, what your history is, surgical history. There's a lot of questions there, and kind of what your idea of passing through quickly, because sometimes people assume that it's the food they just ate that's going through. And sometimes depends on what you eat too, because there's fermentable there's different types of fiber. There's soluble and insoluble. And insoluble fibers will pass through you undigested, but there's probiotics and prebiotics in those fibers that are still happening and good for your gut. So they're still good for you to consume. And so sometimes people say, well, as soon as I eat, I have to go to the bathroom. Well, your stool is always, your colon has always had stool in it. You're not completely emptying your colon unless you've had a bowel prep to come and see us for a colonoscopy. Otherwise, there's stool there. And so that's a normal reflex for when you eat, for there's a gastrocolic reflex to make things, you start having peristalsis. And so it triggers you to move things through because more food is coming in. So you're basically making way for that food. So it's not that you just ate and you immediately are eliminating that food. That food is still making its way through your small intestines. But it's whatever was already in your rectal bowel and in your sigmoid colon that is deciding, okay, it's time for me to move. Some new food is coming in. So yeah, I have a lot of questions for her to see what else is going on and what could be contributing there for sure. But don't worry that those insoluble fibers aren't being digested though, because it's an insoluble fiber. And so people will see, kale or spinach or sometimes like that kind of undigested, or corn is a big one, and they're insoluble. So.
Right. Well, when I interviewed Dr. Goldhammer for the summit, he said, if you're seeing corn in your stool, you're not chewing good enough.
And that's true too. We see a lot of people who don't chew. And so we're in at 2:00 in the morning sometimes for food infections, when people get things stuck in their esophagus. So that's true. Most people chew too quickly and just swallow whole. So that's also very true.
Yeah. Great. Well, we were talking about kale, and Anna, watching from Finland, says every time she eats kale and cruciferous vegetables, she has terrible gas, and she's so embarrassed, and she's sad because she loves eating them and doesn't want to stop. What is wrong with my stomach, and can I get help?
You're not alone. You're not alone. That's also pretty normal, actually. There's some cruciferous vegetables that basically you have fermenting, and so they produce more gas than others. So those are things that, people have to take bean or something before to decrease that amount of gas, but you're not crazy and you're not abnormal. That's actually quite normal to ferment gas because it's just that food kind of breaking itself down. So yeah. It's one of the things it's like just with beans or something like that. We have to decide when you're going to eat it and when you're not, but nothing's wrong with you. And we see it a lot.
Great, thanks. This one, listen, if you can't answer a question, it's okay. And I'll tell people to have the consult because this is sort of complicated, but it's kind of interesting. From Maria, she said that at 17 in 1978, she had Crohn's disease and has been on all kinds of medications throughout the years, with Remicade being the last until November of 2013, when she had her colon removed. She doesn't take any medication now, and her Crohn's is in remission. She feels great, and she's transitioning to a completely whole food plant-based lifestyle without sugar, oil, and salt, having a hard time giving up salt. But she said she moved, so she had to establish a new gastroenterologist. He says she needs to be on Remicade or something like it for the rest of my life. I'm scared of what all the medications I've taken will do to me as I age. I don't want to take medication since I'm in remission and not having symptoms. What would you suggest to a patient like this? If you want me to tell her to have a consult, I will. But I'm wondering, those are really strong drugs and people do take them for a very long time, don't they?
They do, yeah. And she's definitely a more complicated patient for sure, especially if you've already had a colectomy. But that, again, you'll be a person that I have a lot more questions for. Like, did you have small bowel Crohn's as well? What exactly surgery did they do? Did they leave a rectal stump? Did you ever have any issues with strictures or fistures? Fistulas or strictures? Have you had an MRI, endoscopy of the small bowel to see if anything else was going on? What are your inflammatory markers or numbers? So I would have a lot of questions. And some people do need to be on Remicade to remain controlled, because remember that when you have inflammation through the colon, patients with inflammatory bowel disease are at higher risk for colon cancer as well. So it's not just about keeping the colon healed from an inflammatory bowel disease perspective. It's also because it puts you at risk for colon cancer, which is why patients with inflammatory bowel disease have colonoscopies more frequently than the average person. So there's a lot of questions I would have there for sure. Congratulations on the diet, though. That'll be awesome. That can only help. But I'm hopefully you had that conversation with your gastroenterologist about, kind of what else kind of what else has led up to your Crohn's and what was your specific phenotype and what else is going on in your small bowel. Because remember, with Crohn's, it can happen anywhere in the GI tract. So if it was ulcerative colitis and you had your colon removed, then you'd be done. But with Crohn's disease, it makes me wonder where else was the disease affecting in your throughout your GI tract. So that's a little bit more complicated, although sometimes patients, Crohn need to be on Remicade, Humira, Entyvio, Stelara, whatever medication they're on. And yes, they are medications that I don't, prescribe lightly. You think about all the risks, all the benefits, you think about the patient, and make sure they understand kind of what's going on. But also it's knowing the alternative of patients being really sick and not doing well and kind of having kind of a failure to thrive type of syndrome, and also being at risk for that colon cancer as well. So they're kind of, it's outweighing the risk and benefits on that one. But that one's a tough one that, it needs a lot more questions there. And if it's a gastroenterologist that you don't feel comfortable with, you didn't feel it answered your questions, find another one. There's a lot of us out here. Find another one, get somebody that can get to the bottom of your questions and explain to you why you need to be on them and kind of give you those reasons.
Oops, where did she go?
Uh-oh.
That's okay. I'm sure she'll be back. Guys, you can follow
Yes.
her on Instagram at Dr._Janese Laster. And I've been posting her website. Louise is saying, I've learned so much today from Dr. Laster. Yeah, really, you're amazing. So do you ever run into Dr. Barnard in Washington, D.C.?
I don't. I'm going to have to find him, though. I ran into Will in South Carolina. I've run into Vanessa Minutes from other plant-based MDs. So it's been awesome trying, running into some of the plant-based GI folks around. So not Neil Bernard yet, but that is he's literally one of the people that I read. I read all of his books and, Michael McGregor. And these are people that, have definitely taught me a lot along the way for sure during this journey of learning.
Do you know him?
No.
Want me to introduce you?
Yes. Friends in high places.
Well, when you've been vegan for 43 years, you tend to know people. Well, this has been amazing, but you know what they say in show business, you always want to leave people wanting more. So you're welcome to come back anytime. I know a lot of people watching live had questions, but as I mentioned, I have to give priority to the ones that actually type it up and send it in, because that's only fair thing to do. Well, I wish you luck with your new venture. Guys, please check out Dr. Laster's website, especially if you'd like to do a telemedicine. Unless you live in Washington, D.C., you can see her in person. I sure wish I had an amazing female vegan gastroenterologist. That's such a long, hard word to say and to spell. GI doc. Yeah. GI,
that works.
Well, I will ask one more question, just because people do keep commenting on your skin being so radiant. Other than eating a very healthy diet, any beauty secrets? Because really, skin is built from within.
Let's see. I am like a skin fanatic, because I used to get, when I ate worse, I used to get so much more acne. But vitamin C and exfoliation and lots of water.
Yeah, water's great. Water's great. Well, good luck with your venture. I wish you every success, and I can't wait for the GI Health Summit to come out so people can see your interview. It looks like October, maybe November now, because every time I interview an amazing person like you, I learn about a new person. So from you, I learned about Dr. Frame, who's going to be an interview, and it's just this may take a year to get everybody.
He's awesome. It's going to be so good.
I can't wait. Thank you so much, Dr. Laster. It's been a pleasure talking to you. Thank you, everyone, for watching another episode of Chef AJ Live. Please come back tomorrow when my guest is going to be 5 p.m. tomorrow, because he's in Singapore and he can't do the regular time. We're going to be talking to Luke Tan of the Plant Fit Summit. Thanks so much, Dr. Laster. Bye-bye.
Thank you. Have a good one.